You guys like these videos, and I love making them, so let's break down episode 3 of The Pit. This is a rough start because I will say the CPR they're doing here is the compressions are subpar, but we'll get to that. In any case, they're performing CPR because this patient's heart suddenly stopped and technically he's clinically dead. Now, the goal of cardiopulmonary resuscitation is that by delivering that continuous flow of oxygen to the patient's lungs, it can bind to blood, and the chest compressions, it keeps the heart pumping and it can pump the oxygen that's bound to the blood to the brain long enough to bring the patient back. And when I say bring back, what I mean by that is that for every 2 minutes of chest compressions, there's a brief pause and we check out the heart rate monitor and we see if there's a detectable rhythm that appears. Now, initially, when we first begin the CPR, the heart rate monitor shows us a flat line, and that means that the heart has no electrical activity. But when we start the CPR and we start to ventilate oxygen into the patient's body, what we hope happens is that by the oxygen binding to the blood and traveling to the heart first, that small amount of oxygen is enough to recharge the heart and help it gain some of that electrical activity back. And that way, when we take that brief pause every 2 minutes to look at the heart rate monitor, instead of seeing a flat line, we see some sort of disorganized activity. And once we see this disorganized activity, we can then shock the patient and restore the heart back to a normal rhythm. And that's what we mean by bringing the patient back.
Shit. What? I think I just broke some ribs.
It means you're doing it right.
That can absolutely happen, but not with these compressions. And let me explain my criticism. As I said before, the point of doing the chest compressions is that you want to push the chest with enough force to squeeze the heart to pump that oxygen-rich blood to the brain. And sometimes when you're doing chest compressions on someone who's elderly, whose bones are not as dense, you could break a rib as a result. And that's perfectly acceptable because the alternative to that is the patient dies. So it's a fair trade. And I hate to start off on the wrong foot, but like the show has been so good and so medically accurate so far, and like this is what you're going to show us high quality compressions are. Now, I do like the fact that they showed 3 people involved in the CPR. You have one person delivering the compressions, one person in the back delivering the breaths, and then you have someone monitoring the situation. But the compressions, come on. I don't want to be too critical, but they're pretty bad. His hand placement's fine, but the thing is his arms are angled, so they should be straight over the patient. And I'm in the comforts of my own home, so I'm not wearing scrub pants, but you have to, instead of going like this, you have to push down right. You have to go straight over the patient. And I say this because if you're angled, not only are you wasting energy because you're applying force this way and down, but if you're not putting your whole body weight into these compressions, you won't be pushing the chest deep enough to kind of stimulate that blood flow needed. And in a real situation, what you want to do is that you want to lower the patient's bed. That way, as the compressor, you can get into a position where you can be directly over the patient's heart and you can give forceful and meaningful compressions, and you don't have to do this, you know? And another thing, when Whitaker is delivering the chest compressions, you can see he's visibly drenched in sweat, which, don't get me wrong, it's extremely tiring to do the compressions. But it's so important that someone takes over the role as a chest compressor when he looks that tired, even if they're saying otherwise, because you want to be delivering as high quality chest compressions as possible. And what high quality chest compressions are is that for a period of 2 minutes, you're delivering compressions at a rate of about 100 to 120 compressions per minute. And each of those compressions are pushing the chest down anywhere between 5 to 6 centimeters.
How are you feeling? Any pain, Minute?
Marty. Wow. I'm actually really happy they're showing this because for a lot of native English speakers, you may have never needed this machine. Now, what this machine is, it's basically an iPad that will connect us to a live interpreter, and we can bring them to a patient's room, and that way, if the patient speaks a different language, we're still able to communicate. Now, at the hospital I work at, we call these Martys, but that's just the company name who owns these translators, and depending on what company makes them, the names change, so I'm not really sure on all the names. And how this works is, let's say you're a doctor, and you only speak English, and you have a patient that only speaks French. What you do is that you'd wheel these things in. You saw that the iPad's kind of standing right here. You'd wheel it into the patient's room, you click an app, and it will connect you to a live interpreter, and it comes up like a FaceTime basically. And as you talk, the interpreter hears you on the FaceTime, and it will translate what you say into French, and as the patient talks, the interpreter hears, and it will translate what they say into English, so you have a conversation. But what's even more impressive is that not only are they showing you the machine, they're showing you the proper positioning of where the interpreter should be in respect to the doctor and the patient. And that's just what's so upsetting with the CPR scene, because they're getting all the fine details perfect, but yet something like the compressions. As a doctor, when you use a live interpreter, the conversation still has to be between you and the patient, not you and the translator. So what this means is that the camera on the iPad, like they showed here, should be always facing the patient, and you should be looking at the patient as you speak to them and as they respond to you. And not only does this help keep the conversation personable and help build trust between you and the patient, but if you just focus solely on the interpreter and not the patient, you're going to miss a lot of nonverbal cues like any sort of pain in their voice, confusion, hesitancy, and these are essential things that you need to pick up on this while you're communicating with a patient as a doctor. 40 minutes of CPR, that's a long time to be doing CPR for. I'm surprised.
Don't suppose you'd let me try a pericardiocentesis?
For what?
For practice.
Seeing that they're trying to save the patient's life and asking a question like that is extremely disrespectful.
This is a teaching hospital.
It's not a cadaver lab.
What do you call this?
Seeing this kind of rubbed me the wrong way, and I don't know how Dr. Robbie stayed so calm after she asked him this, but in any case, out of respect for the patient's dignity, if I'm trying to revive a patient and I hear a question like this, I probably would have lost my cool, but maybe I have a lot of growing up to do, but in any case, I want to work in an environment where the people I work with practice medicine with a sense of humanity. You know, that's it. And I'm proud to say that whether it's from my medical school or any hospital I volunteered or worked at, it's widely taught and understood that the respect that healthcare providers have for our patients doesn't stop just because their heart stops. It goes beyond.
What happened? My friend. Hey, where is she? My friend, she's in my car. She won't wake up. Okay.
In case you're wondering how a packed emergency room like this can accommodate a critical case on the fly, well, hospitals, they follow something called the surge protocol. And what this means is that they always have a bay on reserve. They always have a room on reserve. And we call this a resuscitation bay. And this room has its own set of equipment, has its own team. And that way, when a critical case comes in and needs immediate attention, everything's ready to go and they can see it immediately, regardless of how busy they are.
What's her name? Jenna. Come on, Jenna. Wake up for me, baby.
So my first thoughts as a doctor, when I see someone unconscious, the first thing you want to do is spend no more than 20 seconds to just do like a little mini assessment. And a mini assessment, what I mean is that you check to see if the patient's breathing, you check to see if they have a pulse, you check the color of their skin to see if it's cyanotic. You also check to see if they have any obvious injuries such as trauma, bleeding, check to see if they respond to your voice and do a sternal rub like we see Dr. McKay do here. And last, you want to check to see if they have any bracelet. Perhaps they have like a medical bracelet that says their condition as to explain why they're unconscious, maybe some important allergies you have to know. So these are all things you got to check for. And I say you want to be quick about this because the ultimate goal is that you want to bring the patient from the car into the emergency room. That way you can do the full assessment, which starts with the ABCs, which I mention this every episode. You want to first check for an open airway, then you want to listen to their breathing sounds, and last you want to look at their circulation.
Pupils, pinpoint. I need.
Narcan.
Yep.
That's a bad one to, I'll admit it, I forgot it. It's a bad one to forget. But when someone's unconscious, you definitely want to open their eyelids up to check their pupils because by doing so, you're doing a brain exam on the patient. Now, how you look at someone's pupil properly is that you first want to just open up their eyelid and look at the pupil with your naked eye. No lights or anything like that. Then once you do that, you can shine a light into the pupil and recheck it. And when you do that, you'll see one of four possibilities. First off, you might notice that the person's pupil is completely normal. What this means is that when you first look at their pupil with a naked eye, their pupil is a normal diameter. But when you shine the light into their eye, it constricts and gets really, really small. What this indicates is that the light that's being shined through the eye is being registered by the brain in response. Your brain is trying to communicate with the muscle that controls the size of the pupil, the neurons or cranial nerves, and it's telling it to constrict and get smaller so less light gets in, and it's essentially protecting your retina. And seeing this is reassuring because that tells us that there's no immediate brain injury at that very moment. Now, the second possibility is that when you look at the patient's pupils, they're already constricted without having to shine light into their eye to make them small. And we call this pinpoint pupils, and the medical term for this is meiosis. Now, what's usually responsible for someone who's unconscious with pinpoint pupils is some sort of drug overdose with an opioid, like fentanyl, heroin, morphine, because what opioids do is that you take them and they bind to the opioid receptors on your brainstem, activating the parasympathetic nervous system, which causes constriction of your pupils, among other things, which we'll get into. Now, the third possibility is that when you look at someone who's unconscious, their pupils can be already dilated, meaning they're very, very wide. And the medical term for this is mydriasis. Now, the pupils, they usually stay dilated even when you shine a light into them, and this usually indicates a severe brain injury, either by hypoxia, which means that too much time has passed and the brain already depleted of oxygen, or by direct trauma. And usually the brain stops responding to stimuli and it's irreversible, and usually the brain dead. And the last possibility that you might see is that when you check the right and left pupils, they might be different sizes, and the medical term for this is anosocarea. We see this happen mostly when someone gets hit to either side of the head. So let's say you have an injury on the right side, your brain will start to swell, a lot of pressure will build up, and because of that, structures get compressed, and cranial nerves are also involved, and as a result, you have unequal pupils. In this case, Dr. McKay, she did the proper thing. She yelled at pinpoint pupils, so we're assuming that it's an opioid overdose. And I'm really surprised that guy just whipped out the Narcan real quick. He had it on hand. But we talked about Narcan in the last episode. It's also known as naloxone. We give it to patients who have symptoms of an opioid overdose. And what it does is it goes into the body. It finds where the opioid binds to the receptor on the brainstem, and it disconnects it. And by disconnecting the opioid from the receptor, it reverses its effects, and the patient regains consciousness. Now, in a lot of Hollywood movies, they always show that when an EMT gives someone Narcan to kind of revitalize them, they always come back right away, like clockwork. But the time it takes for the person to really come back to consciousness all depends on the dosage of opioids that the person took compared to the dosage of Narcan that they put in their nose. So the nasal bottle that you see, every squirt is about 4 milligrams of Narcan given, and you could imagine that the more opioid that a person takes, the longer it takes for the Narcan to kind of go in there and decouple all those opioid receptors and reverse the effects.
Do you know what she took?
No.
This could be a sign of something really serious, and we're gonna have to do a lot of tests that you really don't.
Like half a Xanax.
That's not nothing.
Hold up. First off, you're a med student. Don't say that. And second, when you come off judgmental to what the patient's telling you, the patient's not going to feel comfortable, and therefore they're not going to tell you the whole story. So that's a no-no. So this girl, she said that she took Xanax, and Xanax is actually a class of drug called a benzodiazepine. And what these drugs do is that they help people relax who deal with anxiety, who deal with stress, and they're actually called anxiolytics, right? So they reduce anxiety. Now, in regards to making her unconscious because she overdosed, that's not the case. A benzodiazepine will not cause someone to go unconscious. What I think happened, what I know happened, is that the Xanax that she bought from the street most likely was laced with fentanyl. And the reason I'm so confident in saying this is that the Narcan wouldn't have worked if this was truly like another drug besides an opioid. And since Xanax is not an opioid, it had to be laced with an opioid, fentanyl, which is very common in today's days. Therefore, the little amount of fentanyl that she did take mixed inside the Xanax caused her to go unconscious. Now, in the last episode, we did talk about how drugs can be laced, and these are done by drug organizations and crime groups. And the reason they do this is to make the drug cheaper to make and to make it more addictive so people buy more of it. And it's very sad. It's a crisis, and as you can see, families are torn and affected by it.
Since the last epi.
Okay, that's it. Hold compressions.
Now, usually a code blue team, they'll attempt to do CPR on a patient for about 30 minutes. There's no time limit set in stone, but they'll do it for about 30 minutes before saying the patient's non-revivable. And like we said, if a round of CPR is 2 minutes, in that 30-minute period, the patient will receive 15 rounds of CPR. But even if the patient that they're trying to revive gets perfectly executed CPR, if too much time passes between when the patient's heart initially stopped beating to when they're actually receiving the CPR, the brain can already be depleted of oxygen, and the patient has already developed irreversible brain damage, and no amount of CPR would help at that point. In fact, here's this chart I made, and it shows you how drastically a person's survival rate drops the longer they go without CPR. So as you can see, early on, a couple minutes without CPR, you'll have minimal brain injury, which is still very dangerous, don't get me wrong, but your chances of survival are pretty high. But once you pass that 5-minute period, then you get to that serious brain injury that even if they do resuscitate you, you're still going to be left with permanent injuries. And once you go past 10 minutes, you can see that your chances of survival are less than 10%. So by then, your brain's completely depleted of oxygen, and you're most likely going to be brain dead if you do manage to survive. So here's the thing. With this scene, I think that the writers of the Pit are so good that they intentionally included something like this because it has a really powerful meaning in regards to what has happened so far in the episode. Let me explain why. So a few moments ago, we saw the resident, someone who is in a position of actual medical authority, make a really inhumane request and say, hey, since the guy's gonna die, you mind if I use his body as practice? And now you see someone who's not even part of the medical team, custodian, take a few moments and say a prayer for that very same man who just flatlined. And I think by showing us two separate people with two completely different roles and the response to the very same situation, the man dying, what they're trying to show us is that humanity, or conducting your duties with a sense of humanity, is a choice. Humanity is not something that comes with a title or it comes with a position. You choose to conduct your duties with humanity.
We checked for reversible causes of cardiac arrest on ultrasound.
Okay, good.
So this is a debriefing discussion talking about the patient who just died in the case. And
Does anybody have anything that they wish had gone differently?
In the hall. You should have been on a cardiac monitor. We would have caught the arrest right away.
So after a case like this, where unfortunately the patient died, the medical team can usually do a debrief. And when a team debriefs a case, they talk through what happened. They talk about what went well, what went not so well, and what they can do differently next time. And this is not like some Jerry Springer episode where one person's like, oh, you did everything, it's your fault, or anyone gets guilt tripped. It's not like that. We have these debriefs because we want to improve the hospital system and improve the experience for the next patient we see. The goal here isn't to look back with guilt. It's to move forward with insight.
So I freaked out, and then in the ensuing melee, he shoots me.
First off, kudos to him for not pulling the nail out, because usually when someone gets stabbed, their first instinct is to pull whatever's in them outside their body. So
Come on now.
No, sir.
Whoa, definitely intracardiac.
I gotta tell you, this hurts.
But without knowing the depth of the nail inside the body, you really can't tell what layer of the heart is affected. Now, I know everyone has a basic understanding of the function of the heart, which acts like a pump to circulate blood throughout the body. But in order to understand the severity of an injury like this, let me do a brief rundown of the overall anatomy and the layers of the heart. Now, the heart has 4 layers you should know about. The innermost layer on the inside is known as the endocardium, and that's a smooth lining, and the smoothness allows blood to transfer through it very easily. The second most inner layer is the myocardium. This is the thickest layer because this is the actual muscle that allows the heart to beat. And on the outside, we have the epicardium. Now, those 3 layers, the endocardium, myocardium, and epicardium, they're surrounded by a protective sac that the heart has known as the pericardium. Between the layers and that sac is a little space, and in that space is a tiny amount of fluid in which acts like lubricant, so the heart can beat over 100,000 times a day without any friction. So keep this all in mind because it's more than likely going to come up when trying to determine what kind of treatment this guy needs.
Any allergies to medication?
No. Can you give me something for the pain already? Is this a hospital or a vet clinic?
I mean, I know he's cussing and yelling and all that, and he's very animated, but I'm so surprised. I mean, the nail has to be in his heart. I'm not really sure the extent of the injury, but in any case, I think that the nail right now is acting like a plug, and if he were to pull it out, he'd have severe blood loss and he'd die. So good thing the nail's still in him, and I guess we have to wait till the ultrasound to see the extent of the injury.
No jokes, just pushing your pain meds, buddy.
Small pericardial effusion, but no evidence of tamponade.
Not yet.
Okay, this is exciting because whatever we talked about before is about to come into play now, so let's break this down. So the doctor said, based off the ultrasound, there's a small effusion, but no evidence for tamponade. So what's happening here is that outside sac that we talked about, in which the heart sits in, the pericardium, has been penetrated by the nail. And since the nail is still in him, there's tiny amounts of blood leaking into that pericardial sac, and in addition to that fluid we talked about, that lubricant fluid inside the sac already, blood is being added to that slowly, and that's what an effusion is. And like I said, that pericardial sac should just have a little bit amount of fluid in there to act as a lubricant so the heart can beat frictionless. But since the nail penetrated that sac, blood is actually slowly leaking into that sac, filling it and building pressure around the heart. And as more and more blood fills that sac, the pressure goes up and the heart starts to get squeezed. And the problem is the heart isn't just a pump. In between beats, the heart has to relax so it can fill with blood, so that when it does constrict or pump, there's blood inside the heart to be distributed across the body. If too much fluid fills that sac and there's a lot of pressure on the heart which squeezes it, the heart can't relax to fill with blood. So even though the heart still remains beating, it's barely pushing blood through it to the rest of the body. And that's exactly what a cardiac tamponade is. And even though the ultrasound shows no evidence of that taking place right now, Dr. Robbie thinks that eventually that slow leak of blood into the pericardial sac will allow enough blood to come in, and this is what's going to happen.
I will destroy you on Yelp. Nobody's ever coming to this hole again, I swear to God.
From your mouth to God's ear.
Dr. Robbie's funny.
And insert the tube around the bend.
You stole my med student from triage?
Medical students would never, just think about the situation. The guy has a nail in his heart. He needs immediate surgery. You're going to think that med students are going to intubate the patient? No, that would never happen. Med students don't do this much, especially a third-year medical student. So
Pressure's down, 72-38.
Effusion has grown, now with RV collapse.
So Dr. Robbie was right. Enough blood actually came into the sac, and since there's so much pressure, the heart is squeezing and can't relax to fill with blood. So even though it can still beat, there's not a lot of blood filling it and not a lot of blood being distributed by the heart. So we see here his blood pressure dropped severely, and in order to compensate, his heart rate goes up. So right now what they're doing a thoracotomy. They're going to go into the chest so they can remove all that pressure, opening up the cavity.
Full suction.
The suction.
Get rid of this nail before I get poked.
And now they can remove the nail, because once they remove it, they can patch it right up. So
Piece.
Your forceps, opening the pericardium.
So in this scene, they're treating the cardiac tamponade, and to do so, you have to relieve the pressure around the heart. Now, like we said, the pressure is coming from the excess fluid within the pericardial sac. So the goal of this treatment is to go inside the pericardial sac and drain that excess fluid. And by doing so, you relieve the pressure so the heart can fill normally, it can relax, and therefore, when it does pump, there's plenty of blood to go around. Now, there's actually two methods that you can use to drain the fluid in the pericardial sac. The first way is known as a pericardial centesis, and what we do here is that we use a needle and we guide it with an ultrasound into the pericardium, and that's how we drain the fluid. Now, like I said, it's much less invasive than what they did here, but we can't do it in this guy's case because he's actively bleeding. So even if we were to stick the needle and drain the fluid, since he's actively bleeding, the sac would just fill right back up and we'd have to do the same thing over and over again. And that's why they went with the second method, known as a thoracotomy, where you open up the chest and you have direct access to the heart, where you can make an incision to the pericardium, you can drain the fluid, relieve the pressure, and ultimately you can fix the source of bleeding. And like we just saw, when they did cut the pericardium, they used a suction device to get out all that excess fluid and blood, and they were able to remove the nail because they were right there and they were able to close the source of bleeding, patch everything up, and he should be good to go. And by the way, that small amount of lubricant fluid within the pericardium that we talked about in a normal heart, once you repair the pericardium, that fluid regenerates, so the heart can still beat frictionless.
Excellent hemostasis. Cut here.
I don't know if you guys caught this, but did you see inside his chest cavity when they were operating on him? It was filled with these blue towels. Now, these towels are sterile, and surgeons, they pack them like this to create space so they can work with their hands, and also it controls bleeding so things don't get messy and they can see what they're doing. It's also worth noting that the surgical tech responsible for bringing all the tools to the room, as well as the towels, has to keep track of every towel that they use. She has to collect these towels to make sure that anything that was placed inside the guy's body was removed, because in a lot of cases, there's tools and towels and a lot of other instruments left in patients' bodies after they're done operating. So once they're stitched up, they'll do like an x-ray or some sort of imaging exam, and they'll realize, oh my God, we forgot something in this guy's body, and we call this a never event.
Oh, Stemmy's arrived.
You got this?
Just wrapping him up.
20 minutes of substernal chest pain, 10 out of 10 with dyspnea and diaphoresis.
Diaphoresis means that they're sweating, and dyspnea means shortness of breath.
1 millimeters of
nitro
ST
spray
elevation in the
sublingual.
anterior lead.
These are sometimes called tombstones.
Those right there, they're reading EKGs. I see this and I get excited because I get to teach you guys. Now the term STEMI, that's just a type of heart attack and it stands for ST elevated myocardial infarction, which you'll know why in about a minute. First off, to understand this, a myocardial infarction is just a medical term for heart attack. And heart attacks happen where arteries that deliver blood to part of the heart get blocked, so that part of the heart doesn't get enough oxygen, and that's what causes the chest pain. Going back to the STEMI, there's also an NSTEMI, which stands for non-ST elevated myocardial infarction, and these are both heart attacks which differ in the degree in which that artery gets blocked. Now, if the artery that gets blocked is only partially blocked, we call this an NSTEMI, but if it's completely blocked, we call it a STEMI, which is more serious. And how these blocks occur is that years of time mixed with poor diet, you have fat and cholesterol plaques that build up in these arteries and clots form. Now, doctors, we can tell the difference between a partial and complete block by running an EKG test, which looks at the heart's electrical activity, and also it will tell us which of the arteries is blocked as well. On a normal person, an EKG shows a regular pattern which has a P wave, a QRS complex, and a T wave. But when someone's suffering from a heart attack, we look very closely at one segment of this pattern, which is the ST segment. If this segment were to be elevated on the EKG test, we'd assume that there's a complete block, so we'd call this a STEMI. If this segment were to look normal and not elevated, but yet the patient still has symptoms of a heart attack, this is usually due to a partial block, which we call an NSTEMI.
It's not very good. We're going to send you up to the cath lab. A cardiologist is going to unblock that with a balloon and leave it open with a stent.
Now, in order to treat someone with a heart attack, you have to relieve that blocked artery so that the heart can receive blood normally again. Now, doctors, they're able to relieve the clot by going in with a thin tube, also known as a catheter, through the femoral artery, which is down by your thigh, and by way of dyes and x-rays, they can kind of navigate through all the arteries until they eventually get to the clotted artery. Once they're able to find the clot, they insert a tiny balloon into the catheter and they inflate it. What this does is it pushes that plaque which caused the clot to the walls of the artery. Then they'll take out the balloon and they'll insert a stent, and the stent is just a little mesh framework in which they put in permanently to keep blood continuously flowing. There's also post-care procedures after the stent, which the patient usually takes blood thinners for a certain period of time, if not lifelong, and this just prevents clots from forming so something like this doesn't happen again.
2 saves. Totally awesome.
One thing with Mel or Dr. King is that you can tell when she's speaking to her coworkers, things are a little awkward. I think because she's so pure and genuine, she assumes that everyone's as enthusiastic as she is when it comes to working in the hospital. And when they don't match her energy, it makes things look like she's out of sync. But in reality, she's just trying to make connections and they're making it really hard for her.
Dear, some days it does. I'm sure the rest of your shift will be better. Shake it first. Oh, but make sure the lid is...
My sister does this to me all the time when she leaves the almond milk cap open and I shake it and... So this right here is a scrub dispensing machine, and it's for hospital staff, doctors, nurses, and all alike to scan their badge, remove their dirty scrubs, and place them in the machine. And in exchange, either the same day or the next day, they can take a fresh, sterile pair of scrubs. And this is really important because in high-risk areas of the hospital, like the ER, the operating room, you want the staff to be wearing sterile, clean scrubs to prevent any sort of unnecessary spread of infection. And the only way the hospital can really guarantee that everyone's wearing clean scrubs is to put the scrubs in this machine so they can wash them in really, really high temperature waters and make sure they're sterilized before the staff grabs them. So right here is me. This is me using the scrub dispensing machine when I did my surgery rotation in Baton Rouge, Louisiana. Now, as you can see, I scanned my badge, and since I already from the previous day deposited my dirty scrubs, I was able to collect a fresh pair of scrubs. Now, anyone who has scrub access to these machines at the hospital, the way it works is that you scan your badge and you have a certain amount of credits, which I'm not going to get into, but basically how it works is that you take a pair of scrubs and let's say you get them dirty. The only way you can get a new pair of scrubs is if you deposit the old pair in the machine. It will register because these scrubs are from the hospital, so they have a little barcode. So when they pass through the machine, it scans the code. It registers that, hey, this guy returned the scrubs, and it'll allow you to take a new pair. And I bring this up because if you thought for a second I wasn't going to call out this scene for being BS, you thought wrong. In case you haven't noticed, every person on the show looks like they've been baptized in fake scrubs. And kudos to Figs for landing that deal. Nothing against them, but the actuality is that only the scrubs that you get from the hospital can be placed in that dispensing machine. You can't just put any random scrubs that you buy from your home and then put in the machine. They will be rejected. Not to be nitpicky, but see this? This is a screenshot from episode 1, roughly about 3 hours ago in Pitt time, and our med student over here, he's wearing Fig scrubs. You can see the logo clearly. It's not hospital scrubs, so therefore you can't just put non-hospital scrubs in that machine. It'll be rejected.
Brain dead from a fentanyl overdose.
This was a case from the last episode where that teenager, he overdosed and he died.
Yeah, only child, and I just think that the parents could use a little help processing what they're going through.
What about donation? Is he a candidate?
The transplant counselor could get him there, but I think we're a ways away from calling them in.
So in this situation, we have a teen who just died from an overdose, and the parents are obviously still mourning, and the social worker and Dr. Robbie, they're discussing if he's an organ donor candidate, and maybe they should have the organ donor counselor speak to the parents to see if this is something they want to do. Now, I know it may sound a little insensitive to just bring up all of a sudden, but you have to understand that when it comes to organ donations, you only have a certain window that you can collect and harvest the organs from the donor before they're non-viable. Because as soon as he gets pulled off the life support, the organs and tissue, they start to lose oxygen and they'll start to die. So if this conversation doesn't happen early on, the chance to save multiple lives with the organs that they harvest is gone. And as uncomfortable as this conversation might be, at the same time, there are patients who are awake and conscious who are depending on this opportunity to survive. And it's not about rushing grief. It's about not missing the opportunity to kind of take something good from a horrible situation.
Hey, been looking all over for you. We need a cardiovert unstable AFib in North 1.
Okay, just give me a sec.
Systolics 90.
Now, to translate what Dr. Langdon just said, there's a patient that needs to be shocked via an electrical cardioversion because he has atrial fibrillation and his blood pressure is really low. Just an FYI for anyone who doesn't work in healthcare, whenever you hear the word unstable put in front of a physical illness, that implies that the person's blood pressure is really low. So unstable AFib.
35-year-old architects working on a deadline, vaping nicotine all night.
Nicotine is a stimulant, just like caffeine.
Palpitations this morning, AFib at 147. Mr. Quinn, this is Dr. Robbie.
Hello, sir. How you feeling?
I feel like I've been talking about the heart the whole time. So now that we talked about the layers, let's talk about the chambers of the heart. So the heart has 4 chambers. It has 2 up top and 2 below. At the top, you have the right and left atria, and at the bottom, you have the right and left ventricles. In order to move blood across these chambers, the heart has an electrical system known as the cardiac conduction system, and this is a natural pacemaker that sets the heart rate. And because of this conduction system, you have synchronized contractions in which the atria and ventricles, they contract and relax at different times in order to effectively move the blood through the 4 chambers. But in atrial fibrillation, what happens is this conduction system starts sending chaotic signals to the upper left atria, and instead of contracting, relaxing effectively and efficiently, it starts to quiver, right? It starts to fibrillate. And what that means is this left atria can't relax, so it can't really fill with blood, and yet it's ineffectively pumping, so not a lot of blood is moving through. So instead, when blood enters the left atria, it swirls and kind of sits in there and forms clots, which are very dangerous. So in terms of this case, this gentleman, he smoked a lot of cigarettes, and cigarettes contain nicotine, which is a stimulant. And when you overdose on these stimulants, what happens is that electrical system that controls our heart gets thrown off, and as a result, you get chaotic signals, which can lead to atrial fibrillation and palpitations. And when we use an EKG to check the heart rhythm of someone who has atrial fibrillation, we get a very distinct pattern known as irregularly irregular, which is different than someone who has an irregularly regular pattern. Now, in irregularly regular, that means, yeah, the heart rate is irregular, but it's occurring at regular intervals. With someone with atrial fibrillation, where it's irregularly irregular, it's an irregular heart rhythm occurring also at irregular intervals. I cannot tell you how long it took me to understand that concept. It's so simple, but I don't know what I was thinking. And the reason that this is such an emergency is because due to the left atria not letting your heart contract and fill properly, the amount of blood being moved through the heart and pumped to the rest of the body per minute is drastically decreasing, and we call this your cardiac output. And because of this, you can see his blood pressure severely drop, meaning that he has less blood being delivered to vital organs, and as a result, his body enters cardiac shock and eventually will develop organ failure. So they want to treat this as soon as possible.
Charged.
Clear.
Bingo.
By shocking the patient's heart, we're essentially resetting that cardiac conduction system, and that irregular rhythm that he's suffering from will then be normalized and the atrial fibrillation will be solved. But after this, the patient will most likely need to be on blood thinners for about 4 weeks, because someone who had atrial fibrillation during this episode, blood is not effectively traveling through the heart, and they can swirl and sit and form these clots. So what ends up happening is that when the heart contracts again, those clots that form in the heart can travel through arteries, and one of them is the cerebral artery. This can cause a stroke. So we put the patient on about 4 weeks of blood thinners to prevent these strokes and break up these clots and make sure he's okay. Well, that's it for episode 3 of the Pit, but rest assured episode 4 is on its way, so I'll see you next time, guys.